A woman named Clara Dawson, 67 years old, is sitting in a plastic chair at a bus station in Haywood County, Tennessee. She's clutching a folder of medical records and a handwritten note that says, "Please tell my daughter I tried to make it." She's waiting for a 3-hour bus ride to her dialysis appointment because the hospital 12 minutes from her home closed 6 weeks ago. Clara is not alone. Right now, across 17 states, 1.7 million Americans are losing access to emergency care, not because of a natural disaster, not because of a war, because of a policy decision made in Washington. This is happening right now. I need you to do something for me. Pull up a map of your state. Find the nearest hospital. Now calculate how long it would take you to get there in an emergency at night in bad weather with chest pain. For 46 million Americans living in rural communities, that calculation just became a death sentence. I'm Helen Morland. This is the Morland Report. The mainstream media is calling this a healthcare adjustment period. I call it what it is, a controlled demolition of rural American medicine. I spent 15 years inside healthcare policy. I sat in the rooms where these decisions were made, and I left because I couldn't stay silent anymore. Let me show you what's really happening. To understand this crisis, you need to understand one number, 2.8%. That's the Medicare reimbursement increase that rural hospitals needed just to break even this year, to cover inflation, staffing costs, and the rising price of medical supplies. What they got? Zero, a complete freeze. On February 14th, 2025, the Centers for Medicare and Medicaid Services announced that Medicare payment rates for inpatient hospital services would remain flat for fiscal year 2026. No adjustment, no inflation indexing, nothing. For urban hospitals with diversified revenue streams, this is survivable. For rural hospitals, where Medicare patients often represent 60 to 70% of all admissions, this is an execution order. Here's what they're not telling you. I obtained internal projections from the National Rural Health Association dated March 2025. According to their analysis, 87 rural hospitals are currently operating with negative margins, not thin margins, negative. They are losing money on every single patient they treat. The freeze didn't create this crisis, it accelerated it. Let me break down how the system is supposed to work. Rural hospitals receive reimbursement from Medicare based on something called the Inpatient Prospective Payment System. Each year, CMS is supposed to adjust these rates based on a market basket index, essentially the cost of doing business. When inflation rises, payments rise. That's the deal. Except in 2025, the administration bypassed the automatic adjustment. They cited fiscal responsibility and program sustainability. Internal memos from the Office of Management and Budget, documents I've reviewed, show projections that freezing rates would save approximately $8.4 billion over 10 years. What those memos don't calculate is the cost of what happens when hospitals close. And this is where it gets really disturbing. Let me tell you about Memorial Hospital of Carbon County in Rawlins, Wyoming, population 8,700, nearest alternative hospital 108 miles away in Laramie. Memorial had been operating since 1912. 3 generations of families were born there. Last November, they announced they would cease inpatient services. By January, the emergency department went to standby status, meaning they could stabilize patients but not treat them. I spoke with a former ER nurse named Denise Harmon, 54, who worked there for 22 years. She told me what happened the night they turned away their first critical patient. A rancher came in with crushing chest pain, she said. Classic heart attack presentation. We had to call the helicopter. It took 43 minutes to arrive. He coded twice in transit. He didn't make it to Laramie. She paused. His name was Bill Westbrook. He was 61. He had grandchildren. This is not an isolated incident. This is a pattern. Since 2010, 150 rural hospitals have closed permanently across the United States. But here's the acceleration you need to understand. 23 of those closures happened in the last 14 months alone. The American Hospital Association released data last month showing that rural hospital closures increased 340% compared to the same period in 2023. Let me show you the numbers state by state. Texas has lost 26 rural hospitals since 2013, more than any other state. Georgia has lost 9, Tennessee 13, Alabama 8. These aren't random distributions. They cluster in states that didn't expand Medicaid, where the patient population is older, sicker, and more dependent on federal programs. And here's the key to everything. The Medicare rate freeze hits these hospitals hardest precisely because they have nowhere else to turn. A hospital in Manhattan can offset Medicare losses with private insurance payments, commercial rates that are often 150 to 200% of Medicare. A hospital in rural Kansas, their patient mix is 65% Medicare, 20% Medicaid, and the remainder often uninsured or underinsured. When Medicare freezes, they don't have a cushion, they have a cliff. Now, watch what happens when a rural hospital closes. It's not just the emergency room, it's the entire healthcare ecosystem. The primary care physicians leave because they can no longer admit patients. The specialists stop coming for weekly clinics. The pharmacy closes because it can't survive without hospital foot traffic. The ambulance service gets overwhelmed with long-distance transfers, so response times double, then triple. A study from the National Bureau of Economic Research tracked mortality rates in communities after rural hospital closures. What they found should terrify every American. All-cause mortality increased by 5.9% in the 5 years following a hospital closure, not among the elderly. Across all age groups, for time-sensitive conditions, heart attacks, strokes, traumatic injuries, mortality increased by over 8%. These are not statistics. These are your neighbors, your parents, your children. Let me tell you about Jackson, Missouri, population 15,000. Their hospital, Southeast Health Center, converted to a rural emergency hospital designation last year. Sounds reasonable, right? Emergency services without the full inpatient burden. Here's what that means in practice. Maria Gonzalez, 34, went into premature labor at 32 weeks. Under the old model, she would have been stabilized and delivered at Southeast with the NICU on standby. Under the new model, she was stabilized for transport and sent by ambulance to Cape Girardeau, 28 miles away. Her daughter was born in the ambulance on Highway 61. Both survived, barely. I kept asking, why can't you just help me here? What Maria told me, and they said, we're not allowed to anymore. So this is not a funding problem. This is a policy choice. The administration's response has been what I can only describe as willful blindness. In March, the Secretary of Health and Human Services testified before Congress that rural health care remains a priority. He pointed to $12 million in rural health grants, $12 million for a crisis affecting 46 million people. That's 26 cents per person. Meanwhile, internal documents from CMS show they're projecting accelerated facility conversions through 2027. That's bureaucratic language for more closures. They know, they're planning for it, and they're not telling you. Now, I need you to understand how this cascades. When hospitals close, the domino effect is devastating. First domino, emergency response times increase. National EMS data shows average response times in affected counties have risen from 8 minutes to 23 minutes. For cardiac arrest, survival rates drop 10% for every minute without defibrillation. Second domino, healthcare workers leave. Rural areas were already facing a physician shortage. The Association of American Medical Colleges estimates a deficit of 14,000 primary care physicians in rural communities. Hospital closures accelerate the exodus. Why would a young doctor move somewhere without a hospital to admit patients? Third domino, economic collapse. Rural hospitals are often the largest employer in their county. When they close, the job losses ripple through the entire community. Housing values drop, tax revenues fall, schools lose funding. Fourth domino, population decline, families leave, young people don't come back, the community hollows out. This isn't theoretical. This is already happening in Becker County, Minnesota, in Wheeler County, Oregon, in Perry County, Kentucky. And here's what happens if this continues for 6 more months. The National Rural Health Association projects 42 additional hospital closures by January 2026. The Healthcare Financial Management Association estimates 130 more facilities will enter critical financial distress. By 2027, according to their models, 1 in 4 rural Americans will live more than 60 minutes from emergency care. Have you noticed how quiet the administration has been about this? Have you wondered why there are no press conferences, no emergency task forces, no presidential statements? Because they're hoping you won't notice until it's too late. What happens when a wildfire tears through rural California and the nearest trauma center is 2 hours away? What happens when the next pandemic hits and there are no rural hospital beds left to surge? What happens when your elderly parents who moved to the country for peace and quiet can't get to a doctor in time? This is not speculation. This is the trajectory we are on. Here's what you must do. First, know your nearest 3 hospitals, not just one. Have addresses programmed into your phone. Know which ones have trauma centers, which have cardiac catheterization labs, which can handle stroke. Second, if you have elderly family members in rural areas, have the conversation now. Discuss contingency plans. Consider medical alert systems. Know their medications, their conditions, their doctors. Third, document what you're seeing. If your local hospital reduces services, if your ER wait times are increasing, if you're being transferred further for care, record it, report it. The only way this changes is if the evidence becomes undeniable. Fourth, if you're outside rural America, don't think you're safe. Urban hospitals are already feeling the overflow. When rural systems collapse, the pressure transfers to you. I need to hear from you. Comment below right now with your state. Tell me, is your local hospital still open? Have services been cut? What are you seeing on the ground? Subscribe right now. Share this video with everyone who needs to hear it, because the people making these decisions are counting on your silence. History is being written right now, and we are documenting it in real time. I'm Helen Morland, and this is the Morland Report.